Okay. Hi, everybody. Welcome to DocTalk. Today, I have the distinct pleasure to introduce a friend of mine, and I can't believe this day that I did not ask him to talk about this. And I can't find a more perfect person to talk about this question of prolonged QT, torsades, and how it affects by hydroxychloroquine and Z-Pak or Zithromax together. Dr. Subh Agarwal is kind enough to be here, a friend of mine from residency, and we have been talking about for a long time about health. And so today I want to introduce to you Dr. Subh Agarwal. And he's Dr. Agarwal, why don't you tell about you a little bit about your background? This is so extraordinary. I've never met a person with so many strong board certification degree. I don't even know how you even have time. You must be 100 years old to be able to accomplish all this.
Well, thank you, Dr. Truong and Ban, for inviting me to your podcast. It's ironical that we are talking about these drugs. You and me are at the forefront of trying to see how we can move our family, ourselves, and our patients to get away from drugs. Yeah. And here we are talking about how we can save lives with some medications which are, I think, essential here. Yeah. As far as my background is, I've had extensive training. And I have, we worked together in the emergency department back at the University of Illinois in Peoria. And before that, I had done internal medicine training. So I'm dual certified in internal medicine and emergency medicine. And after that, I practiced for a few years emergency medicine. And then this bug again entered me. And I ended up doing a master's in cardiovascular epidemiology and translational medicine and statistics at Wake Forest University. And then I did clinical cardiology fellowship in Detroit. And then I did electrophysiology training at Northwestern Chicago. After that, it was enough. And now I've been practicing, cardiology for quite some time. I am practicing and teaching cardiology at the Medical College of Wisconsin in Milwaukee at this time. And today we are here to discuss very important issues. So I'm very glad that you've invited me to discuss this today.
It's very interesting to me that nobody asks like somebody with your expertise. So we always ask infectious disease doc for this medication. And you have to realize before this, infectious disease doctor never given that medication. It's the rheumatologist who give this medication extensively, right? And so throwing somebody who infects disease with COVID where nobody's seen before, how do you become an expert? So let's sort of go back. And one of the biggest debate is this idea of hydroxychloroquine, right, and Zithromax are both produce what they call prolonged QT. So I'm going to ask you, what in the world is prolonged QT and why are we so worried about it?
Yeah, I mean, it's a loaded question.
Yes.
QT interval is difficult to understand. Mm-hmm. So I just wanted to simplify it for everyone. We are looking at QT intervals mostly in the cardiology department, in the clinics. I'm looking at the QT interval and particularly the corrected QT interval, which has more relevance. So, I drew a diagram for folks to see if it is easy to understand. So basically, the cardiac myocyte or the heart is an electrical pump. Mm-hmm. It is pumping blood. And also it is an electrical pump. There is electricity flowing through its cells. And it has automatic cells which generate electricity. And these we call them natural pacemakers of the heart. So the electricity is transmitted through the heart in a graded fashion. And we call that the action potential of each cell. So the action potential basically of the cardiac cell is a coordinated action of turning on and turning off of different ionic channels. So you can imagine that each cell is behaving differently over time. And when you combine it together and put electrodes on the chest, which you and me are familiar with, it creates a picture on a running paper, which we call an electrocardiogram, EKG or ECG. And this, again, these are big words, but basically we call this depolarization and repolarization of the heart muscle.
Yeah.
So basically what it means in simple English is relaxation and contraction of the heart muscle. And when we capture that in totality on the EKG, surface electrocardiogram, you see all these squiggly lines.
Yeah.
So some of them we call a P wave, QRS, T wave. So this delay of time between the start of depolarization and complete repolarization is the QT interval.
Yeah.
And it's an interplay of various electronic ionic channels on the cardiac myocyte.
So just to summarize, it's basically the electricity that goes through the cells is what caused the cell to be able to signal and allow the heart to contract. And when the heart contract is what you're pumping the oxygen up the blood through the lung to be able to gather the oxygen to come back, and you're cycling the oxygen. But in order for that to function, the electrical signal is that what that QT is. Right? So that's normal that your body does on a regular basis. So what happened when it prolonged?
So normally, again, it is impacted by a lot of factors.
Yes.
So as I just mentioned, each cell could behave differently. So there is variability of the QT interval. And it is affected by our hormonal status. So women have different QT interval, men have different QT interval. In fact, some studies show that if 450 milliseconds is the time of QT, if it is more than that, it is abnormal in men. Mm-hmm. And somewhere between 460 to 470 milliseconds is abnormal in women.
Yeah.
So gender affects that. Circadian rhythm, when we are sleeping in the night or we are active. Autonomic tone, our heart rates, when we have a faster heart rate, the QT interval actually shortens. Mm-hmm. And when we have a slow heart rate called bradycardia, the QT interval prolongs. Yeah. So it is affected by a number of factors, which could be either our own human factors, or it could be affected by outside entities. And here we are discussing drugs.
Yeah. Oh, that's very, very interesting, because it's going to lead me some of the question I'm going to have for you down the line. So now if I have prolonged QT and that interval between the Q and T start to widen, depending whatever factor, and we'll talk more about that, how long are we talking about, and when do we start worrying about to lead to a next question is called Torsades point, right?
So that's, again, I think a loaded question, because sometimes you can have a normal QT interval. And even in these patients, they are prone to have something we call the Torsades du point, or Torsades du point. It's a French word. Mm-hmm. Which basically means that the heart goes into this polymorphic electrical storm called ventricular tachycardia, and then degenerates into ventricular fibrillation, which you and me see on a regular basis, having worked in the emergency departments and in the cardiovascular world, where we have to shock these patients or take away the offending agents. So in broadly speaking categories, we have two categories of long QT. So one is congenital, where they may have some kind of genetic mutation. And the second is acquired. Mm-hmm. So in the acquired category are drugs, which largely is preventable, provided we know about it. And in the congenital form, you have these genetic mutations, which can affect different ionic channels. So the one which we have long QT syndrome 1, which happens in folks who they have syncope and they have cardiac arrest. And these patients normally will have symptoms with exercise while swimming. So it's related to exercise. And the gene is KCN, Q1. Again, we don't have to go into those details. Yeah. And in the long QT syndrome 2, is the one where you can have an auditory stimuli. So some alarm goes off and it can lead to torsades.
Yeah.
And the third one happens during sleep, the long QT syndrome 3. There are others, the Anderson-Tawil syndrome, where they have polymorphic features.
But these are pretty rare, though, that we're talking
They're
about.
rare.
Yeah.
The more common are the acquired.
Yeah.
Now, in the cardiovascular world, again, when we say rare, in the whole world, it's low. It is one of the more common congenital abnormalities, though, I feel like, in the cardiovascular world. Now, we have a selected population, obviously. We are seeing patients with syncope. They refer to us, so we have higher prevalence in our clinics.
Yes.
Compared to in the general population. Yeah. But if you look at the general population, the torsades is 4 out of 100,000 people.
Wow.
Which is 0.004%.
Yeah, that's very low.
So it's very low.
Yeah.
Now, in the predisposed population, it could be higher.
Yeah.
Because when a cardiac arrest happens, we do not have the luxury of getting an EKG. You hear that someone died in a car accident or died while swimming. You can presume that they may have had long QT syndrome. But that, even autopsies will not give us that idea because they have normal hearts. Now, the second part which can cause long QT is the acquired syndromes, which are mostly drug-related. So there's a slew of medications which can cause the prolonged QT. And they normally affect something called the IKR current channel. So this is the plateau phase of the repolarization of the action potential. And if there is defect, either genetically, but here we are talking about acquired. So drugs which can block this IKR current or the HERG channel, that can lead to prolongation of repolarization. Yeah. So imagine that the heart is still taking time to completely come back to its native state. Yeah. So when the heart is repolarizing, the time is increased, you can have something we call a prolonged QT. Here I drew it. So if you can see that you are seeing on the surface ECG, it will come up as a prolongation of the QT interval.
So that's the red part that you're showing us.
Correct.
Right.
So the red part
is what we talk about when you're extending the time of that interval. Right.
You're extending the repolarization time. And on the surface ECG, you will see that as a QT prolongation. So all fine. You have a patient or someone who has prolonged QT, but not all prolonged QT will lead to torsades.
Yes.
You could have prolonged QT, but not all of them will turn into torsades. So torsades is very rare phenomenon. That's what I'm trying to say. Yeah. You have to have other things going on. So the problem is that when you have prolonged repolarization, your calcium channels might become active, and you may have early depolarizations.
Yeah.
And if they're sustained and they have sufficient magnitude, they can cause torsades. That's the mechanism of torsades. And the heart can then go into fibrillation, and there is no flow to the brain and body. And then they present with seizures or syncope without any warning.
Yeah. So I think that's the one thing that we always hear question is this idea of prolonged QT. And so from what I'm hearing from you is like prolonged QT does not mean that it will lead to torsade.
Correct.
And it doesn't necessarily mean that lead to arrhythmia that cause the cell to not be able to coordinate in synchrony to be able to pump the heart. And the way when that occurs, you're not going to be able to have blood flow. So things that happen to people are signs of syncope, meaning they faint, right? They pass out. Other thing is that they can have arrhythmia that lead to seizures. And so a lot of these things are things that people don't know it could be related, but from a prolonged QT to lead to a torsade to arrhythmia is fairly low from what you're saying.
That's true.
Yeah.
That is true. But again, I mean, because we are talking about it and we are, iatrogenically going to introduce medications in our population. So I think we have to be cautious.
Yes. And so that it's going to lead me to the next question is that how often do you see it? I mean, how often do you see prolonged QT that lead to torsade that you have to? So let's ask you a question. Prolonged QT, what's your treatment?
Well, if you have a long QT syndrome, let's start with that. You have a congenital long QT syndrome. The treatment is that you cannot change, of course, the genetic mutation, but we can introduce some certain things. We can tailor therapy. So one is we can introduce beta blockers.
Yeah.
You want to remove the beta agonism, the sympathetic stimulation, so you can maximize your beta blockers.
Yeah.
I think at Mayo Clinic and in some other tertiary centers, they do sympathectomy.
Yeah.
That's endotherapy. And then, of course, we have the mechanical devices like the cardiac defibrillators, which can be implanted. So that's invasive. In the ones which are acquired, you should have a heightened sense of awareness.
Yeah.
So if electrolyte disbalance is there, your potassium is low, your magnesium is low, correct that. Get an EKG to look at the QT interval and correct that using the various formulas.
Yeah.
I use the Bazzett's formula to get the corrected QT interval.
Yes.
Look at the gender. It is longer in females. Rule out any ischemic heart disease or structural disease of the heart failure, or if they have a baseline prolonged QT interval, or if they have a history in someone who is related to them with a long QT syndrome or prolongation of the QT interval, it predisposes everyone in the family.
Yeah.
Prolongation of the QT interval. So we need to be aware of these factors.
Does age comes into play a little bit for you too?
Yeah, I think that's a great point. Yes, age, absolutely. So we are seeing that folks who are 60 plus, they have some, they probably, what happens with them, I think that there's something called QT dispersion, repolarization heterogeneity. So when I talked about repolarization in a cardiac myocyte, imagine hundreds and thousands of cardiac cells are there.
Yeah.
So there is a different QT in each cardiac myocyte. So it's different. And you're looking at it on the surface EKG. So if you look at the QT interval and take the maximum and the minimal QT interval, that's the QT dispersion.
Yeah.
If it is less than 80 milliseconds, that's good. More than 80 milliseconds, you're worried that they may have some heterogeneity of, repolarization, and that can make them prone to develop torsades. And I think that with age, when you have lived 60, 70 years of your life and suffered some insults to the heart, it can lead to difference, in the cells, and can lead to, in my opinion, to heterogeneity of repolarization of QT intervals, which can, I think that's why I think age plays a role in QT and torsades.
And so just to summarize a few things, right? So that really, to me, a few things that jump out at me. So we talk about genetic is something that some people know, and it's related to the treatment that you have that with a cardiologist. And then your family should be concerned because it follows their family line. So that's one. Two is that different gender makes it different. Women will have typically a more prolonged QT. The next thing you do is you look at the age. What you're just saying is that when they're older, especially over 65, you have to be mindful of that as well. And the other thing that comes as well is that keep in mind of people who have some kind of heart issue. So ischemic mean that if they have maybe potentially history of heart attack, stent, things they have to worry about. In addition to that, heart failure is another one that you mentioned. The last one is bradycardia is one that can also prolong. So those are main things that we have to be in mind when we think not only of this medication, but other medication. I want to share a chart that I put together for you. And if you can walk me through this a little bit, because these are medication that we see
Mhm.
And when I looked it up, these are one that known to lead to prolonged QT and also torsade. Okay, so I'm going to share this one, and let's go through together, because you and I, as physicians, especially ER doc, we have prescribed a lot of these medication.
Right.
So if you look at on this particular medication, let's take a look, right? So things I put in sort of different category for us. And the medication that we see on here are a psychological medication, antibiotic, different heart one, if you can address first, and so some miscellaneous one.
Right.
So psychological medication, the two that jumped, the other one that second generation antipsychotic medication, and some of these are first generation that can lead to torsade, but more probable versus these one that's shown. So things that I see my patient on a lot are Lexapro, Celexa, are two serotonin type of serotonin receptor inhibitor that are used as a antidepressant medication. Haldol is one that we use in the past for compliance. So a lot of time we give injection usually once a month, because we know that when we give medication to our patient, it's a low compliance because it doesn't make them feel good.
Right.
Another one is the one that's Aricept, that's used for elderly patient that has some history of some progressive dementia and Alzheimer. So these are things that you see. The next category, antibiotics. So Zithromax is one that's controversial, that combined with hydroxychloroquine. Biaxin is one that's not really given as readily now as it used to be. Cipro, Levaquin. Okay, those are really antibiotics that we give quite a bit. So Cipro we give quite a bit for bladder infection.
Correct.
Levaquin is really give one a lot for, especially in older population that we're worried about pneumonia. So give us a thoughts of what you think of some of these medication. And
one we can add is Bactrim, trimethoprim sulfamethoxazole combination to the antibiotic list.
So I think Bactrim, you said?
Bactrim, yes.
Okay, you got it.
So a lot of medications. I mean, the list is long, basically.
Yeah.
Unfortunately, a lot of, and thankfully, So I think that the way I look at it is that, again, because of the electrical flow in the heart muscle, drugs which are meant to prevent arrhythmias, so the class 1 agents, the class 3 agents. So class 1 agents, antiarrhythmics, are mostly sodium channel blockers.
Mm-hmm.
But of them, they have subtypes. So if you look at quinine, which you put as cardioquine in the heart, that's a class 1A agent. And then if you look, flecainide is a class 1C agent. So flecainide, not so much. Flecainide mostly causes more of a QRS prolongation, not necessarily a QT prolongation. But the class 1 agents, although they are classified as sodium channel blockers, they also have potassium blocking effects, the current blocking effects, and that causes prolongation of the refractoriness, repolarization, and that leads to increased QT interval prolongation. So you see that with quinine a lot, with procainamide, not so much with class 1C agent, flecainide or propafenone. But when you look at class 3 agents, those are pure potassium channel blockers. So if you look at the one which is not in the heart here is dafetilide or ticacin. That is known to cause QT prolongation. And we are scared of that medication. I use that a lot because it causes QT prolongation and can cause torsades, I initiate that medication in the inpatient setting. We admit the patient for 3 days.
Yeah.
And we give the medication. And then once there's no change of QT interval, which is not more than 500 or 550 milliseconds, we let them go home.
Yeah.
Immunoderone is one which is more permissive. It has effect on sodium channels, potassium channels, calcium channels, beta channels. So it is more protective. So even with someone who has a QT of 600, I'm comfortable on immunoderone.
Yeah.
So it can cause QT prolongation, but we don't see torsades with amio much.
Yeah.
And the miscellaneous, I mean, I have used it so much when I was in practice in the ER.
Yeah.
Zofran, ondansetron.
Yeah.
I mean, I give that all the time. Haldol, I've given it so much.
Yeah.
I mean, patients are, there's a book called Prozac Nation.
Yeah.
Folks were on fluoxetine and Celexa and Lexapro. In fact, even the second generation, third generation psychotropic medications do have potential to cause QT prolongation, but they are being used.
Yeah.
And not everyone is having torsades. But if they do have prolongation of the QT, then we may have to withdraw that medication or introduce a different medication. Looking at antibiotics, erythromycin is the one which causes the most QT prolongation in macrolides.
Yeah.
If you look at the potency of macrolides, it's erythromycin, then clarithromycin, then roxithromycin, which is not even used, and then azithromycin. So the potency of azithromycin to cause QT prolongation is much lower in the list.
Yeah.
And when you look at levaquin, yes, it also the same story. It is much lower in the list when you look at fluoroquinolones. Yeah. And when they looked at the pharmacokinetic profile, the serum concentration of levaquin has to be very high than used in clinical practice to cause QT prolongation.
Yeah.
But since we are talking on a population level, you have to be careful. When you introduce drugs on a population level, even a smaller percent can lead to a large number, absolute number of folks with QT prolongation.
Yeah.
So I think that's where the concern comes from.
Yeah, and the reason I put this together so we can see is that, like, for example, a lot of people are on the medication for a long period of time, and so when we talk about, and we'll talk about how do we put everything together, right? So you talk on Lexapro, a lot of the serotonin reuptake inhibitor, it's really hard to come off of it, so a lot of patients who are on these, I think it's near impossible to come off these medications. So patient been on easily a decade of these medication. In addition to that, you're going to have medication that you give for Alzheimer or even dementia that can be on there. The antibiotic, you're not going to have it on there for a long time because the goal is try to get them on maybe 7-10 day max, and you're off of the medication. But think of other medication that people are on there that also when they give them antibiotics, you give an antibiotic, you give diflucan, if by chance if they had some kind of vaginitis, right? Some yeast that people are on, so you add it onto it. But for example, I see this quite a bit out of the ER. In this case, was giving a Z-Pak or Zithromax and giving Zofran because people don't feel well and they start having nausea and they go home. And then imagine if this person have these serotonin reuptake inhibitor that they've been on for years, right? So you got a lot of things that are happening all at once. So it's not as straightforward. I want people to think that just D2 medication is self-causing problem. No, you got a lot of people on medication that's been there for a long period of time.
Yeah, I mean, polypharmacy, you and me understand is an issue, but I think you make a great point that you selected some common drugs which you and me have taken.
Yeah.
I have taken Zithromax, many years ago, and Levaquin when I had bronchitis.
Yeah.
So I was not doing an EKG on myself to look at it and then repeating it every day. So I think we are living in a state of heightened awareness and being too cautious when we're dealing with such a deadly disease, which is killing people. Here we are, talking about common sense approach using the art of medicine versus, waiting for things to clear up on its own.
Yeah.
And coming up with all these theoretical considerations. So I think you're doing a great job by discussing these and bringing it to the attention of the viewers and patients.
Yeah, and I'll show you some of the cases, and you and I can talk about this. Look how complicated these are. Okay, so recent cases that I have are like I have an 80-year-old lady, right? History of high blood pressure, diabetes, and on now starting off having fever, severe malaise, cough, having trouble breathing, having diarrhea. Right. So now look at our list of things. She's over 65. She's a woman. She's having diarrhea, would drop her potassium, magnesium, right? So think of all the different things. Now she's diabetic. She's on sulfonylurea that's going to bring down her blood sugar. She's not eating. So these are very complicated cases, right? And then you're going to come to a person, right? And they're listening to the news. They're saying, okay, now this is day 12. I'm not going to come out of this. Or even day 5, you're miserable. You have fever, 101, 103 fever, and you just feel your body's really being worn down by the virus that's being replicated. Your immune system start attacking yourself, right? So now you come to this person, and you know from the list that you just told me, right? In my head, it would be like, oh my, prolonged QT to Torsades, I'm going to kill this person. Well, they are going to die.
Yes.
If you didn't do anything about it, right? Because I already know this is going to happen. They are not going to be able to handle that viral load, and they're not going to be able to handle the amount of what the immune system is going to do to you. So you can see it's not an easy question to ask, right, for people. And you're going to come, and I come across this all the time. I say, look, these are the issues that come, like that this thing can happen. But also other medication that you even have the same type of effect.
Correct.
These are the chances that we have. What would you like me to do, right? And if you feel like this is what's going to help you, I will do it. But you can see it's not as easy as saying, give it to them, they're going to live. I'm saying, if I give it to you, you have a better chance. I can't even guarantee you by the time that I get a phone call from you that I'm going to be able to save you. But you're gonna make that decision, and you're gonna make it collaboratively with the family and the patient. Because sometimes the patient are so sick they cannot make that decision. So that's why there's some that's easier. You got 20, 30 years old. You can say, well, they're gonna be just fine. Well, you know what? They feel like they're gonna die too. So they're gonna spread to you, your family, and other things. So that's why, I want you to get your thoughts on it, because I don't want to feel like I'm the only crazy person that's saying, I want to give this medication, but I've gone through and weigh out all the scenario. And once I give it to them, they got my full attention. Not only am I monitoring, like, what's their intake like? What are their supplements look like? What are other things that I'm trying to support them? And we'll talk about what I'm supporting them. And I'm on the phone with them about 3-4 times a day. I'm managing their diabetes. Like, their own doctors only manage it. I'm managing all these for them, because I know what will happen when you give medication, whether it's insulin to sulfonylurea or even sodium glucose co-transfer inhibitor like Farxiga, how it's going to lead to ketoacidosis. I've seen that happen. So it's very complex. And I want people to appreciate that this is just one tip of the iceberg. But you as a physician, we have to weigh everything and help people understand that. So give me your thoughts on these things.
You very succinctly, you have just shown that you are truly practicing the art of medicine. That's what it is. You have just put it very succinctly. And I really truly believe in the shared decision making. So we are not being paternalistic now. We are approaching the patient individually and tailoring therapy and telling them that, listen, when I do a procedure, I tell them that this is the risk of a procedure and this is the benefit of a procedure. And together we make a decision of doing the procedure or not, looking at all the risk variables. Same with, exotic medications, which we use every day. Unfortunately, more and more medications, we are coming with great therapies, like you mentioned, Farxiga, which is the SGL2, and anticoagulants. We have to make these complex decisions on a daily basis with each patient. Mm-hmm. But so same thing with the introduction of macrolides or antimalarials we are talking about in this current situation. But before we get there, I think we should also discuss what is the literature.
Yeah.
What is the evidence? So I have mentioned before that absolutely we are scientists. Before we are physicians, we are scientists. Folks who are not aware should realize that I'm talking to a PhD in nutrition before you became a physician. So we come from a background where we are trying to make people take less medicines, but here we are talking about introducing medicines. Mm-hmm. But we are also trying to, in addition to medicine, what we are trying to do is improve and boost the immune system, mm-hmm. using alternate therapies, but also looking at true science. So where did this literature come from? There are some studies which talked about the benefit of these medications. So if you will, looking at chloroquine, let's say, or hydroxychloroquine, which is the hydroxyl derivative of chloroquine, the way they did it, that quickly the scientists were able to look at the structure of the coronavirus, SARS coronavirus, type 2. And they were able to sequence the structure. And they found that these spike proteins, from where it derives its name, this corona spikes, the S protein, it is able to attach to the epithelial cells of our respiratory system, to the ACE2 inhibitor. So that's one mechanism. What they found was in their study, because they were able to see the structure, they found that the chloroquine binds to sialic acid and gangliosides, and it helps in binding it to the ACE2 receptor. So in the presence of chloroquine and hydroxychloroquine, this binding of the coronavirus to the ACE2 does not happen. So that's one mechanism. And second, they found that it increases the liposomal pH. And that was the mechanism why it was being used and is used for immunomodulation in SLE and rheumatoid. And they found that that mechanism is also effective for coronavirus. In vitro studies have been done in the past and today, which show that it can prevent the replication of the virus. And I think we wanted to give a background to say that why we think that this medication can work. Same thing they found with macrolides, particularly Zithromax, that it has also some immunomodulating property and can prevent the replication of this virus. So they used a term called drug repositioning. So these drugs have been in use for years, for decades, and no one talked about it.
Yeah.
And every day people are using Plaquenil for rheumatoid and SLE.
Yeah.
And so they repositioned the drug for use in this current pandemic, I should say. Mm-hmm. And then there are some trials, when we have that 100-patient study from China, and there's an 80-patient study and a 36-patient study from France. Mm-hmm. Now, I understand that they're not clean. There's a lot of noise. Mm-hmm. So we are waiting for randomized trials. But while we wait, we can't let people perish.
Yeah. I
think you and me have a responsibility to cautiously use this medication, which you have had tremendous success with.
And, I appreciate some of the comments from some of the people out there. They want me to talk about some of the story. I tell success story and hoping to get hope. And there's also stories that are not successful. And I know of 3 of those cases, right? End up in the hospital. 1 is still on a ventilator, and 2 older gentlemen who pass away. And unfortunately, that's what happened. So there's a few steps that lead to there. And most of the people do well. But what I find is that you have to manage so many different things. It's not about just giving this medication, give the antibiotic, and say goodbye. It will not happen. Right. They need round-the-clock help, and they need guidance. Family call me all the time. They text me, they call me, and I give them guidance. And for example, if you give a medication and it causes a person, it's very simple, right? You give this medication. I find this a lot in women. You give this medication, they have diarrhea. right off the bat. They have diarrhea, right? So you imagine you get 400 milligrams twice a day, next day, diarrhea. Well, if you have somebody who's weak, barely can take fluid, having diarrhea that drop their potassium and magnesium, they are going to feel worse. So what are you going to do about it? So you can sort of see how complicated this can be, right? And then the next question is, okay, their oxygen started to drop and it dropped to 94. What are you going to do about it? Do you say, right? So these are things that you have, because not only would affect to me how they feel and just the thing that you maintain, I believe it affects their red blood cell, and it makes that oxygen harder to bind to red blood cell. That's why some of the oxygen drop. By intubating them early, you're not going to save them. And that's what you've seen. A lot of the ventilator can damage if you run it incorrectly, it can cause more injury. So there's a lot of things that goes through there. But I appreciate one thing I want to go back and talk about, okay? To me, what you said were very important. So the two steps I think are important is, one, you have to stop the spread and the replication of the virus is one. Two is that now you have to figure out how to deal with your own immune system, because over time, your immune system is what's going to kill you. And you hear the term cytokine storm. And those are two things I see that progressively start with one and it leads to two. And so just to reiterate what you said, is the reason hydroxychloroquine works is how it helped to decrease the replication of the virus. It also makes it more basic and makes it harder for the virus to replicate, okay? And so the next part is, the third part is that I think what you're saying is the Zithromax, to me, we always talk about some infection that occur after you get the infection. But I think the reason they work together is there's some antiviral with the macrolide, the Zithromax, and hydroxychloroquine, but it also had anti-inflammatory property. That's why people fever start to drop. Then my myalgia drops significantly. If you're having fever and pain for a week to 2 weeks, I guarantee you're not going to feel very, very comfortable, and you won't be able to sleep. And I throw back to what you said earlier, which it made me think a lot more. And I'm going to ask you this, is your circadian rhythm. You talk about that specifically, how that also can affect your prolonged QT. So now you can see all these things that people will worry about, all the medication, but think about if you didn't sleep for 10 to 12 days, what is doing to your circadian rhythm? What is going to do your cortisol, your stress hormone? Because this is a hormonal related signal that your body uses on a regular basis. So I'm going to lead to the next question of all the things that I think was so perfect. What you do is talk to me about the different supplements. Talk to me about vitamin C. Talk to me about vitamin D. Talk to me about zinc, right? That we always talk about. Talk about even quercetin. Talk about melatonin, right? So give me some sense of what are things, because you are not only a cardiologist, but on your YouTube, you really approach from a holistic point of view. And I want to share that YouTube that you've been doing prior to this, of how important what you've been doing for everybody.
Right. So going back again, Zithromax has anti-inflammatory property. Also, it is an IL-6 blocker. I just wanted to throw it out there, because when people are very sick, they are giving them drugs like tocilizumab, which is an IL-6 block, So Zithromax has the same property. So I think there is some immunomodulation and anti-inflammatory effect of.
That's a great point. I love that one. Yeah.
In addition to what you're seeing with SCQ. Now, so let's talk about some complementary drugs, such as zinc, for example.
Yeah.
So when you give, zinc, we know that it causes the RNA-dependent, the virus RNA-dependent RNA polymerase.
Yeah.
It affects that, and it prevents the replication of the virus. So we have seen that over the counter, people are using it when they get a common cold, and 30-40% are from coronavirus. Other ones, the human ones. These are the zoonotic ones, which came from animals. But so using that same, so you can use it for that. Second, they found is that when used in the presence of hydroxychloroquine and chloroquine, there's increased iontophoresis of zinc into the cell. So you have added, additive and multiplicative probably benefit of the zinc reaching the right place and preventing the replication of the virus and giving you benefit by decreasing viral shedding, making you seronegative, and boosting your immune system. Similarly, studies like with vitamin C, I have spoken a lot about vitamin C. It is an antioxidant. Mm-hmm. It has anti-inflammatory properties, antiviral. So you can do that naturally with fruits, but if you're sick, you're not going to get that. Some studies, we can reference studies, but some studies have shown that high dose intravenous ascorbic acid or vitamin C can do the same thing. But if you are healthy, you could take oral vitamin C at least at this time.
Yeah.
Similarly, in vitamin D, it has, again, antiviral properties. It boosts our immune system. Again, we are just getting over the winter months. Yeah. Still the sun is not out as much. So you can imagine how much natural sunlight we are getting to even get to the recommended levels. And I think we need much higher levels to feel happy and healthy. And I've done a lot of studies on vitamin D myself. You asked about quercetin and melatonin. Some studies have shown benefit there. I feel like when you talk about quercetin, it is basically a flavonoid, which is present in
base, right? Yes.
Phytochemical. So again, we can talk about mindful nutrition being whole plant-based, diet. So you can get that in berries, let's say blueberries, strawberries, and it is basically an antioxidant. And I think that's the mechanism of action of immune modulation. It has been found to affect apoptosis and has anti-cancer properties. So there's n number of literature out there about the benefit of these simple therapies, I should say. Mm-hmm. So I think in addition to what you and me do, if we pay attention to this, I think we will have much, much better outcomes, in my opinion. And when we see when you talk about QT prolongation, this and that, we don't know if the levels were optimum in these individuals.
Yeah.
They could have had significant vitamin D deficiency, but we don't know about it. And most of these studies which have been done are retrospective analysis.
Yeah.
Someone published a case report, then they went back in time and looked at thousands of patients in observational cohorts, and they found that, there is QT prolongation. But it's not corrected. There's a lot of confounding and noise. So I don't know how to interpret those studies.
Yeah. No, those are great points, and, there are a lot of people that reach out to us and want to know, well, I don't have the infection that they know of. So what are things that we can do about it? So my feelings are always like, hey, why don't you increase your vitamin C? I think it's always somewhere between 1 to 2 milligrams a day, which I take daily. Vitamin D, every patient that I have checked, I rarely see maybe one, if I would check the level, that's above 40. Everybody else is always below 30, which is super low. And imagine, like you said, in the winter month, it's going to be even lower. And so the reason I recommend 5,000 IU is that in vitamin D, you really need to check the 25 hydroxy vitamin D to see, because it's a fat soluble vitamin that it's going to store. You don't want to leave the toxic amount. But I haven't seen that in anybody that measure in the winter that's high, unless they take very high amount. So 5,000, wait 1 or 2 months, you check it again, you can see. I like that level up to 60 or 70. The next thing is that zinc, right? We talk about zinc, and I get this all the time. People are like, Dr. Ban, can you tell about zinc? Zinc's important. I know, I said that's given. I keep saying that zinc is important. And you have mentioned zinc, right? My feeling about zinc is this, right there. Zinc is one that was given by Dr. Zelenko in New York, right? There was a comment that he gave about 220 milligrams. That was a study that came out, right? And he gave for 5 days. And then my impression from his interview is that they stopped. But what I want you to know is that, look, that is just during treatment. What are you going to do when you're at baseline or after? Because you're still going to be sick. A lot of people will tell me after 3 weeks, they feel a lot better, but they're not 100%. So where are your zinc level? So in terms of zinc, I would drop the zinc down to anywhere between 30 to 50 milligrams a day. But I also want to tell them is that you want to add copper, because zinc and copper work together, and zinc and copper will compete at the intestine level, and it won't, if you give one, it's going to affect how the other one's going to be absorbed. And definitely zinc in terms of thyroid, it's going to affect each other. So it's going to affect the ability of thyroid conversion to active form. So that's another great one that we talk about. And then we go to things that you love, right? Which will, I'll have segue to it, turmeric, right? It's something that you love and you have that for a long period of time. And then as far as,
I said I take that every day myself.
Exactly. And I'll have you preach that one too. And then when we go to quercetin, I recommend anywhere from 250 milligrams twice a day or 500 milligrams twice a day. If we're in this stage where we're worried about that, you said it's a plant, it's a flavonoid that you do. It really, to me, has effect on the heat shock protein, that if you block that, it's going to affect the life cycle of the virus. So there you are, and a great antiviral product. So that's one thing people can take. The other one is I learned this one recently. I knew melatonin was important, and I know that as we get older, from our testosterone being lower and progesterone being lower, growth hormone, but melatonin will drop as well, and it's going to affect our sleep cycle. But melatonin is also important as an antiviral. So as you can see, as we get older, that level drops. So it's easier for you to have more of the symptomatic that you find. So melatonin is sort of interesting. When I do integrated medicine, I always measure melatonin first. But if we're here and we're not going to be measuring things that you can consider is somewhere between 5 to 10 milligrams. Most of the pill out there are 5 milligrams. When people are sick and they have coronavirus, I actually recommend somewhere between 5 to 10, because their sleep cycle, like you were saying, their circadian rhythm is all off. So any chance that you can get them to be able to sleep and also decrease the viral load, I do it. But yeah, so that's sort of my go-to that I think about in my mind. And the other one, I do take magnesium on a regular basis. So what I find is people are sick and they have diarrhea, they can lose a lot of magnesium. The one thing I want you to be careful with for people, that magnesium can make you have diarrhea. So normally when I take it, is about 230 some milligram to 300 milligram. You get into 500 milligram. Now, not only hydroxychloroquine is going to give you diarrhea, the magnesium is going to give you diarrhea. So you got to be so there's a lot of things that are that you have to think about. It's not as straightforward,
Remember the days when patients come with severe constipation in the emergency room?
Yeah.
What do we give them? We give them 300 cc's or bottle of
magnesium citrate.
Right. There you go. So I think, again, that's the point. We can go overboard and cause harm as well.
Yeah.
But I think if things are done cautiously under the care of a very, person who really practices true art of medicine, people will do well. Yeah. So I really love your message of hope, which you are giving to folks, because there is no reason to be fearful.
Yeah.
Again, there is a disease which we understand is there, but I think we probably have tools which can be utilized to prepare us, strengthen ourselves, and even if we get the infection, we can overcome it.
Yeah.
But if we are too late in the game, then patients end up with cytokine storm, and they're on prolonged ventilation. And luckily in our hospital, I was talking to our critical care specialist. We have had lower mortality, but I'm hearing stories from my other colleagues all over the country and in fact the world.
Yeah.
And depending on the care provided and accessibility to care, they have had high mortality, as high as 80% on a ventilator.
Yeah.
So, they are, because everyone is learning on the fly with this condition. Some are giving early intubation, but now we know that later is better. Yeah. And lower tidal volumes are better. prone ventilation is better. So I think people are learning on the job, and I think we will prevail. We are going to win this war.
Yeah,
you and me and others together.
Yeah. I want you to just tell people about your YouTube, what you do, because I want people to know. You're one of the rare cardiologists that are out there, and I appreciate everything you do. From mindful nutrition to the way you approach nutrition. You make everything a lot of yourself. You show people how it's done. So talk about what you do, because I think we will overcome this illness, and we got to be able to think about how to maintain our health. And for long term, that's the reality. A lot of us going to survive. A lot of us will not make it. But we got to understand, how do we continue from this forward?
So I'm hoping that we will take this opportunity to heal. This is a wake-up call. We did go through a pandemic in 1918, and I'm looking at some of the posts. At that time also they thought the world is healing, but we need it more today, I feel like.
Yeah.
People are coming closer. People are working together. So I think that this is a great wake-up call. And basically through my YouTube channel, I'm telling my story that, listen, by engaging in mindful behavior and mindful living, and part of mindful living is mindful nutrition. And we are talking about, if you're healthy, you will be happy, how to restructure yourself through breathing exercises, through mindful meditation techniques, to get the bliss which you and me desire for ourselves and our families, and to develop our own limitless potentials and get the mindful knowledge. So that's the goal through my YouTube channel, which is Holistic Workshop, with the water lily symbol, the flower symbol.
Yeah, I will have our Matt, our videographer, will put it on there, because I want to promote it for you, because I think you do wonderful things, and I hope a lot of our colleagues are out there and sort of step back and think about why we gone into medicine, right, and be less dependent on medication. And that's why it's sort of funny, you and I are talking about the two guys that want to get people off medication and let their body be their own healer, right, talking about a medication that saves life. This is so the irony. This is so sort of funny. You and I talked about this last August when you and I were on this together. But now that's what I think you're right. That's what medicine is. You approach each problem differently, and when that end, you continue with another part, because it's an evolution of things that are happening.
Yeah. Again, we don't want to lose sight of our focus.
Yeah.
Right now, we are focused on this pandemic, but once this war is won, I think we should re-engage ourselves and in this pursuit of mindful living. Yeah. So that's the goal you have and I have about health and happiness.
Yeah.
So I would be delighted to help, and you and myself in this goal we have to make ourselves and our family and patients, as part of the greater family, healthy and happy.
Yeah. Yeah. Thank you very much. I'm going to summarize real quick for everybody. Okay. So about this idea of prolonged QT, it's really the signal that produced in your body naturally, that it could be exacerbated because of genetic issue. It can be exacerbated because of low electrolyte, like from potassium to magnesium to calcium can cause that, right? So when you're sick, you got to be careful. The next part is what this interest is medication, right? From hydroxychloroquine to macrolide like Zithromax, but there are other antibiotics. There are other medications that are used for psychological. There are other medications that you have spoken eloquently that are used to help people control certain arrhythmia. Okay, so when you put all those things together, these are things that you have to be very mindful of, what medication people are on. in addition to what you intend to put people on the medication. The category of people that you would need to be mindful are people that are female, okay? People that have ischemic type of heart problem, heart failure, low heart rate like bradycardia. You have to look at age, people over 65 years old, okay? And those are things that you have to keep in consideration. You want to talk to the family about this medication. You want to know where they are in their illness and how soon do you need to start this medication. And these are things that you talk to family, then it leaves them a better understanding of what they're getting themselves into. Okay. And so I appreciate everything that you've done today, and your knowledge is like blows my mind. I'm just like so impressed every time I talk to you. So I'm like, I'm like, this is the first time I heard from a person who's an ER doctor who's trained in emergency department, emergency medicine, who gone to cardiology, and in addition a fellowship in electrophysiology as well. So it's very rare. It's a rare breed that you have and rare knowledge. So want to thank you for being here and passing on a lot of the wisdom for us today.
Thank you, Ban, for inviting me. I really appreciate the effort you make, and I have been listening to your podcast, and I mean, you are truly, really, really helping the patients and spreading the hope, because we need hope more than ever. So thank you so much for inviting me today. Thank you.
Okay, thank you, my friend. We'll talk soon, okay?
Okay, bye-bye.